Welcome, everyone, to Season 6, Episode 2 of Gateway Center of Excellence in Rural Health's lecture series, where we are opening the gate to understanding rural health. Today's date is October 7th, 2025, and the topic is Rural Mental Health, Gambling, and Problematic Behaviors. My name is Nyden Greenfield, and I'm your moderator for this webinar and a research assistant at Gateway Center of Excellence in Rural Health. I am joined by a group of mental health professionals to explore this topic today. Statistics Canada reported that in 2018, nearly two-thirds of Canadians aged 15 and older reported gambling within the past year. Many people can have fun with gambling, but a percentage of those who gamble may develop a problematic relationship with the practice. Providing resources and responses to any concerns can be further challenging in rural environments. To discuss this further, I am pleased to welcome Meaghen Brideau, a registered social worker and a counselor at the CMHA Huron-Perth, who will provide a case example of gambling and problematic behavior. Fellow speakers will support the discussion on access points for mental health care in rural communities and their various professions. These include Kathy Liu, a resident physician in psychiatry at the University of Ottawa. Kathy holds a Master's of Public Health from Johns Hopkins University and has a background in health services consulting with a focus on quality improvement and health system strengthening. She is also a newly instated Rural Health Research Chair at Gateway, specializing in the field of mental health. We will also have Nicki Darbyson, who is a registered psychotherapist at the Maitland Valley Medical Center in Goderich, and also has her own private practice. She is passionate about destigmatizing mental health supports. Before we begin, I want to acknowledge the land. Gateway Center of Excellence in Rural Health is an organization dedicated to promoting health and well-being for the diverse communities that call rural areas home. This can include rural, remote, and indigenous lands that continue to face inadequate access to health and healthcare services. The views and opinions in this webinar may not reflect Gateway Center of Excellence in Rural Health, but we believe in providing a platform for meaningful discussion. I will now hand the floor over to Meaghen, who will start off our lecture today.
Hello, everybody. Thank you, Nyden, for the introduction. As Nyden was sharing, my name is Meaghen Brideau. I'm the Problem Gambling and Behavior Change Counselor for the Canadian Mental Health Association Huron-Perth Addiction and Mental Health Services. I have been in the role of the Problem Gambling Counselor for just had my 3rd year anniversary. So I've been doing this role exclusively. I have held other roles at the agency in the 6 years that I have been involved. But today, as Nyden was sharing, I will be focusing on talking about problematic gambling and other behaviors that are impacting folks. So I'll start with going over just a brief overview of the various problematic behaviors that the Problem Gambling Behavior Change Program covers. So as the title states, we offer services for problematic gambling, and that can really be in any form. So we talk about land-based casinos, so that's your brick and mortar casinos. Online gambling, we have noticed a significant increase, in particular online gambling methods such as online slot gambling, as well as sports betting. Those are two really common ones. I also see folks for things like going to things like bingo halls or playing bingo online, slot machines online, scratch tickets, pull tab tickets, bets for horse racing, anything of that nature. So those are different gambling programs or gambling addictions within that program I offer. I also see people for sex and pornography addictions. They're very similar, but we do treat those separately. And again, a wide variety of different sex and pornography addictions. We serve including things like deviant sexual behavior. I do also support folks that engage in child pornography and bestiality, as well as other forms of pornography content, and again, a wide range of different sex addictions, how that can look. We also see people for overeating or specific addictions to maybe something like sugar or McDonald's. We do not cover anything that may move into eating disorder territory, so nothing with anorexia or bulimia. Those we do refer people out to eating disorder services. But we do support with again, overeating or maybe specific addictions that are food related. We do have a temporary pause on our hoarding and cluttering program. I used to provide supports for that. We typically need a two-prong approach for those that are struggling with hoarding behaviors. What that typically looks like is in the counseling room, that would be CBT-based interventions, so cognitive behavioral therapy, things like exposure therapy, challenging those thoughts. And then the second component, which our agency just doesn't have enough of that to support with, is having somebody go with the client to their home. And this is part of exposure therapy to help them declutter that space. If somebody were to just go into the home of someone that's struggling with hoarding behaviors and clean it out, it can actually be more traumatizing for the individual if it's trauma-based reasons for the hoarding and behavior, or if it's mental health based. We can often see it with OCD related behaviors, and those symptoms are not managed. They'll just fill that home again. So not having that person to go into the home and help with that exposure therapy piece, that's why right now we're not offering any hoarding behaviors. We also support folks with addictions to technology. We call it tech use. So this is things like social media, your phone, tablets, web surfing, kind of doom scrolling, anything that involves that type of support. And then it's very similar but separate. We also support folks for gaming addiction. So very straightforward things like video games, whether you play them on your computer, on your phone, tablet, or on a gaming console. I think I've covered all. We do about 7 or 8 different of the problematic behaviors. I do also support folks for substances as well. That is a much smaller percentage of my caseload. I tend to support substance use clients if I need to bulk up my caseload, if I don't have enough clients, and that's not the case right now. So it's more of an overflow piece. So if we just are having many people calling, wanting supports for substance use, and our adult substance use counselors are at capacity, I can take those folks as well. So those are some of the different programs or problematic behaviors within the problem gambling program I offer, again, as well as substance use. So that's a little bit with that. Right now I'm based in Perth County, so I'm joining this webinar from our office in downtown Stratford. So I see people in person, but I also recognize that we do have Huron County that's also needing support for problematic behaviors and substance use. So I will remotely provide services for Huron County clients. So that's through things like we use Microsoft Teams or phone calls if they are not able to come to Stratford to have an in-person session with myself. So that's, again, kind of how I offer these services, what the services look like in terms of the problem gambling program. I worked most of my career within social services, pre and post registration with my social work registration has been rural, but I have spent some time working in the Kitchener-Waterloo area in urban social work and urban social services. And again, very similar. Folks still have mental health and addiction needs, but a little bit of that difference is that within more urban cities, there might be 4 or 5 different agencies that offer addiction counseling, 4 or 5 different agencies that offer mental health supports. Everything is much more centralized. Transportation is much more easier to also, access and move around within these locations. So services are much, again, more easier to access in terms of transportation, a variety to choose from. So that can be that bonus. But for me, something I really like about rural social work that's a little bit different than urban social work, or again, mental health and addiction services, is again, because there's such a variety of different supports to choose from, you may only meet that client once or twice or just see them for something like addiction. Whereas in rural social work and social services, which I prefer more, is I get to work with somebody again in a counseling capacity. I've also worked years in domestic violence as well, and I have maybe worked with that client in that capacity and getting to kind of see their journey and their own recovery and through reaching their own goals is quite miraculous. It's always something that I enjoy seeing, and it reminds me that recovery is possible. People are able to make changes in their lives despite their own barriers they face and challenges. And because in rural communities, there are also less to offer. We are the only mental health and addiction agency that covers Huron-Perth County. So because of that, we also tend to know other service providers that offer different supports. We only have one for children's aid, one for things like probation or parole, one, talk about things like eating disorders I mentioned. So getting to be able to connect and know those service providers well and know the clients is something that's unique to rural supports, which is something that I value a lot. So those are also some things I notice within the work that I do. And also, I wanted to also touch on to maybe backtracking a little bit, but talking about the problem gambling piece, kind of talking about both urban and rural, everybody can struggle with problematic gambling. And what we've noticed is that since online gambling has been legalized, it was April of 2022, I believe. If not, it was April of 2023 from the Ford government. Because at the time we were just kind of coming out of the pandemic, and when everything had to shut down, casinos lost money. So Ford decided to legalize online gambling. There is, I think it's about 24, 25 legal OLG-based gambling sites that you can access. There's literally hundreds of thousands of more that are not legal or a little bit sketchy to access. But with the legalization of online gambling, we have seen, I'm not exaggerating when I say a tenfold increase of people coming in accessing supports for problematic gambling. In particular, we've noticed a lot of individuals, particularly males, probably between the ages of about 16 to 45, that are struggling with a gambling addiction. This isn't something where they gamble too much and they can stop. So the problematic gambling and addictive gambling client numbers have increased significantly, and the age has shifted too. Pre-pandemic, we would often see folks coming in that had gambling addictions who were probably about 50 up. Most of them were retired, already often had a lot of money that they are, financially doing well, and they had money to gamble because gambling at its source is a form of entertainment. But for some people, it can become addictive. So we would tend to see folks where they had a lot of money. Again, it starts as something fun. People don't think that addiction will turn into an addiction. People think that it often is something fun to do to take up that time. And it's entertainment at its core, or depending on the addiction and the reasons for engaging in it, we tend to see this with things like methamphetamine or fentanyl use. It can be where they have experienced something that has been incredibly traumatic that they are just trying to forget. So again, they're not thinking of developing an addiction, they're just trying to almost numb out and forget experiences. So that can be this other avenue things can go, but regardless, they never think it's addiction. So with both, they never think they're going to develop an addiction. So with clients that would come in, again, pre-pandemic, it was entertainment for them. It was fun. It was a way to spend a Saturday. They used it as social hour. Most of the clients were retired age, and then that developed into an addiction for them. But again, what we're seeing now, kind of pre-pandemic, with online gambling being legalized, I'm seeing a client who's 21 years old. Most of my clients are male. I do see female clients, but most of them are male. where they have gotten themselves financially in a lot of debt from their gambling, specifically with online sports betting and online things like blackjack and poker. Not too much with slots, again, in person or online. And this is someone who's 21 years old who has accumulated $40,000 worth of debt, or I have had clients who have gambled away tuition for school, or they've not attended classes, things like car repossession. So it's starting much younger, and with the bombardment of gambling advertisements, it's hard to get away from. We do need to look at regulating them like we do tobacco. And the thing that is very unique about gambling addictions versus something like substance use or other problematic behaviors like pornography use, like binge eating, gambling. We also do shopping and spending. That's another one. I recognize I was forgetting something. So even things like shopping and spending, is that when we gamble, it's all random. No matter what form of gambling you partake in, even if it's games of skill, so skill-based bets, which are things like poker and blackjack, kind of knowing how to read cards a little bit. Sometimes clients will think of, again, skill-based betting with things like with sports betting, knowing your teams, what are the stats, how do the players do? Even skill-based games are still random. And our brain doesn't really register that. So when we are in the middle of gambling, our what we call our limbic system or our nervous system goes on overdrive. So that part's kind of in the middle part of your head, and it contains what we have. It's our amygdala and our hippocampus, and those are things that are involved in storage of memory and of our emotions. And then our prefrontal cortex, which is our forehead part of the brain, that's our logic making, decision making, how we regulate insight behaviors, that part of our brain. So again, it's kind of our forehead part. We call it going offline. Blood will actually leave that part of our brain, and our limbic system, which is more the middle part of our head, that goes on overdrive. And as our brain produces dopamine in excessive amounts, dopamine is the chemical in our brain that addiction thrives on. We need to have excessive amounts of dopamine produced in our brain in order to get that high that our brain is looking for. That high is that release of excessive dopamine. But when addiction we are struggling with, it struggles to kind of pass through certain parts of the brain. And our brain is just needing to have more and more dopamine to feel like it gets this release. So the thing that's really unique about gambling is that our brain, what it can't recognize is that it's not a consistent flood of intense dopamine, where it might be something if you drink 6 beers, if you ingest a line of cocaine, or if you go on a big shopping spree and spend $500. It's not this instant hit of dopamine because it's not consistent, where I drink the glass of wine, I get this hit of dopamine. With gambling, again, whether you're counting, you're playing a card game, you're doing sports betting, you're waiting for that score to come in, you're playing slots, your brain is building up dopamine because of what we call intermittent reinforcement. Your brain remembers that one time when I was playing slots, let's say on my phone on Betty Casino, it remembers I pushed this button and I won $600. So if I push the button again, I'm going to win $600. The brain doesn't recognize that we may or may not know if we're going to win that money. We don't know how much money we have to spend before we actually win any type of money. So, a lot of my clients, they'll actually spend thousands of dollars in one go before they win something like $500. Our brain doesn't recognize that. And when we are making excessive amounts of dopamine, we are experiencing a high, we're numbing out, we're not able to use that rational prefrontal cortex part of our brain to recognize, oh my gosh, I've actually just spent $3,000 and I haven't won any money yet. I need to stop. Or I don't actually know if I'm really going to win anything today. So with this increased building of dopamine in our brain, suspense builds. And then once you win something, the excessive amount of dopamine is released. Or if you lose, I kind of like to think of it like a trap door in the floor. It almost bottoms out and all the dopamine leaves and people can have intense lows. Gambling addiction has one of the highest rates of suicide because of the debt people can incur and what you lose. Things like, again, people lose their home, their car gets repossessed. They've gambled away their retirement or their kids' tuition money. So when the low happens, and because of this suspense, waiting for what we call intermittent reinforcement, the random chance something is going to happen, when that doesn't happen, the lows get so low. But when you win, because it's so random, it's not consistent, like drinking alcohol or, again, going on a shopping spree, the win is so high. And that's also why gambling, when it becomes addictive, we're not able to go back to moderate use. You're not able to go back to a place of just gambling for fun. Clients do have to stop and abstain from gambling. So I recognize the time. I know I was given about 15 to 20 minutes to speak. So I think I spoke a lot about gambling and the concerns we see with that. So I'll go ahead and put a pause with that. And I will now turn the mic over to Kathy, and looking forward to hearing what she has to say.
That's great. Thank you so much, Meaghen. Hi, everyone. My name is Kathy. I'm delighted to be able to join today's discussion. I'll be focusing most of my talk on rural psychiatry, particularly how I got into this field, and then also talking a bit about access and challenges and barriers around accessing mental health services, particularly in rural and underserved communities across Canada, across Ontario. So I got my first exposure to working in rural psychiatry while I was still training at the University of Manitoba. And while I was there, I had a lot of opportunities to work in community and also northern remote mental health settings, caring for patients from rural communities across the province of Manitoba, Northwestern Ontario, and also parts of Nunavut. Many of these communities that I've seen patients from didn't have any satellite medical centers, let alone any hospitals or any specialized mental health or psychiatric services, including psychiatrists, social workers, or clinical psychologists. Most of these communities were only stationed by nursing teams at nursing stations. So the level of care that they were getting there was quite fragmented. And these were very underserved and remote areas of our country. A lot of the higher acuity patients that we were seeing in the urban centers were triaged for medical evacuation from a lot of these rural nursing stations. And they were brought to a lot of these tertiary centers who were better equipped and have the capacity to care for these patients with a lot of the more acute psychiatric presentations. But one thing I realized as I was working with these patients was, although they can come to urban centers when they had an acute presentation, it was really hard for them to continue with engaging in mental health care as they went back to their home communities. And once they leave the hospital, it was hard for them to follow up. They were often lost to follow up until they were evacuated again. So I was really noticing that when we want to engage with a lot of these rural populations, the only opportunities to do that would be in very acute settings. There was no ongoing long-term follow-up or ways to kind of build a more therapeutic relationship with them in terms of a more long-term basis. I also did some work in telemedicine and in virtual rural psychiatry outreach for a lot of these reserves and communities in northern parts of Canada who were just really far from any urban center. But again, as I was working with these patients, I realized that a lot of them were not even able to get to nursing stations because of weather challenges or lack of transport, or really just not being able to keep up with their appointments. And oftentimes there were lack of access to technology, and they weren't really able to attend a lot of these appointments. So the more that I was working with this population, and in rural psychiatry, realized that there was really this gap in care between acute setting and community care for very common mental health presentations. And in the last couple of weeks that I've been training in Ottawa, I've similarly had the experience of working with patients now in rural parts of Ontario who were also really coming to seek mental health treatment or management only when they have an acute episode, instead of being able to really build that long-term therapeutic relationship with them after they go home into the community. So one of the most talked about issues right now in rural psychiatry is around access, and most commonly lack of access to mental health and barriers to equitable access for these rural populations. Right now, the mental health services in rural Ontario are unfortunately very fragmented and not very comprehensive. In a lot of these communities, there is an ongoing lack of access to psychiatric assessments, lack of psychiatrists, lack of regular access to a primary care provider who are really the backbone of our health system. And they're the individuals who can help a lot of these patients living in rural Canada access mental health support and guide them to the right mental health resources. And the cause for this lack of access is really multifactorial. It includes things like just really lack of facility, workforce retention, issues around workforce recruitment, and just overall lack of resources to provide the care that is needed for a lot of these communities. In rural areas, a lot of the ways that people access mental health resources is through the emergency department. As I was saying before, when they have an acute presentation, they will come to the emergency room, and then they can see a psychiatrist or be triaged for an inpatient admission. But once they leave the hospital and go back into the community, it's oftentimes very hard to follow up with them, and they're oftentimes, unfortunately, lost to follow up. So they kind of enter this pretty negative cycle of getting into an acute presentation, coming to hospital, but there isn't really anything to bridge their transition back into the community. So I think just kind of to summarize all of that, when it comes to rural psychiatry, I think it's an area that's in need of resources and workforce retention. And I think something that once we are able to build a stronger mental health system in rural Canada, a lot of the mental health needs for patients in the more remote communities will be better cared for in a more comprehensive and a more equitable way. So with that, I think I'll pass it on to, sorry, I'm just pulling up my list here. I think I'm passing this on to Nicki.
Yes,
That's right.
I think so. Yes. Yeah, thanks, Kathy. Yeah, hi everybody. I am Nicki Darbyson, and I am a registered psychotherapist with the Maitland Valley Family Health Team in Goderich. So I was going to just talk a little bit about the experience of being a therapist with the family health team and what that looks like. I've also worked with the Zurich, the Blue Water and Area Family Health Team, and the Stratford Family Health Team, which is a little bit more urban. Just to kind of give that comparison, I guess, of the services. And really, they are all similar in the sense that when you work for a family health team, the way that people from the community access the services is typically through their family doctor. And the nice thing, I can speak for the Goderich, the Maitland Valley Family Health Team experience, at least, that there's also a dietitian here and a diabetes educator, a care navigator. We have a memory clinic. We also have just, a number of wonderful nurse practitioners and family health team doctors. So there's a lot of different ways in that people can be referred to counseling services. You can also self-refer to the family health team therapy services. There's this one at least, and in Stratford, there is a session limit just because of the wait list that people would experience if they had unlimited access. So what happens is once you have a referral through the family health team, you're triaged, and there's a bit of a wait typically, and then you have 6 sessions per year. And so often when we do a triage call with people, we're trying to match them with a good fit, a counselor that's on the team that's a good fit. And also we're looking for a sense of, do you have benefits to access coverage in the community? Because you just don't have to wait as long if you go straight to a private provider, right? Typically. And so then the people who are on the list are surely those that don't have benefit coverage and access. And just to kind of reiterate some of the points that have already been raised here, our goal in 6 sessions really is to help connect people to other resources in the community as well, because in 6 sessions, we really are trying to build a therapeutic alliance, get to know what some of the biggest concerns are for people, and then help refer them also to places that they can go after, right? So CAMH is a big one. There's really good drop-in counseling resources available right now. We also help people feel connected to different apps. I think that's one of the questions that was raised already. And so there's a lot of, I can send out later a list of the apps that we'd like to recommend. But there's just the Ontario Structured Program as well, which is a really good digital program for CBT, things like that, because we know we are, we're working within a 6-session framework. And for more like critical, urgent crisis type situations, we do refer to the emergency room or to a hotline, because we really aren't an emergency care clinic. So we know that when people are coming in for triage, they're waiting probably about a week to get that triage call, and then possibly another 4 to 8 weeks to get counseling. So it really is more of a, okay, the emergency room is where we go for urgent situations, and we also provide the hotline number as well. And again, in a rural area, we're really fortunate to have a psychiatrist that's available through the emergency department. And we actually have a psychologist as well on staff. And I just wanted to kind of go over some of those differences, because I didn't really know them before I got into the field. But as a registered psychotherapist, I am working on therapeutic goals with clients. I'm not doing any diagnoses. That's a psychologist or a psychiatrist who do those assessments. And we do have somebody on staff here who does that. So if you were looking for something like a formal ADHD assessment, then you can get that through your family doctor. But that's through a psychologist. And we don't have a psychiatrist right on our team at the family health team, but we do, again, have that relationship with the hospital. And to Kathy's point, if you were to go to the emergency room and have an experience there, the benefit of the family health team is that your doctor does get that report, and then they can meet with you and refer you to counseling through the clinic. So there is a little bit of a bridge to services through the clinic then, because of that nice relationship of your chart, right? That your doctor is notified that you were at the emergency room, and that's a helpful opportunity then to kind of have this team of care. And just to kind of also say, we also do a lot of partnership work with Huron-Perth Family Services, because we only work with kids like 8+. Typically, we're working with adults, but we have a number of therapists who work with kids under 12, but 8 is the minimum age. So we don't do direct family therapy or couples therapy here, but we can work with kids up to or starting at 8. And really, the other types of work we do here are, again, this idea of destigmatization of mental health services. So we do a lot of community groups, which I personally love doing. We do, coping skills groups regularly, sleep groups, mindfulness groups, things like that we can offer. And then we're also sharing the resources of other family health teams, because we do stay connected to what they're offering as well. And again, with rural, we do offer a lot of virtual, because it's it's not always easy to get to Stratford every Wednesday to do a group. So we'll do virtual groups when we can. And I know that's not that accessible for everyone either. So we do try to offer in person when we can. It's a delicate balance, trying to make sure that we can meet everybody's needs. And we also do some really fun preventative groups in schools. So we're looking to educate kids on healthy habits and whatnot. We started a running program. We trialed one through an existing program called Team Unbreakable, and it was a really neat 8-week program of offering running service, like running skills groups with mental health content. So that was kind of a fun new thing that we tried out. And really, I'll kind of leave it there for now, because there's so much we could say, and I'll leave it for the question period. So I'll turn it back over to Nyden, and yeah, we'll see what kinds of questions come up. Thanks.
Thank you, Nicki, and thank you so much, everyone, for sharing a little bit about your perspectives as mental health professionals in the rural space. I'm now going to turn it over to the audience. If anyone has any questions, feel free to post them in the question and answer box below, and one of our speakers will be happy to answer them. And these can be anything concerning any of the concepts mentioned today or the work of the individual practitioners here on our panel. I know we did have that one from Michael Beasley. I know, Nicki, you addressed it briefly there, and you said you might potentially list some of the apps that might be available to people who are struggling with gambling or other addictions. I don't know if anyone else would like to add anything on top of that one there.
Yes. I wanted to speak to a question that was put in the Q&A. So somebody asked specifically about apps to help with gambling if someone's experiencing problematic gambling. So that's something I can speak to. We act, so I said we, but there are two different types of gambling apps that are offered. One of them is called GamBan, and that is an app that is based out of the UK, but they do offer it here in Canada. It's somewhere between $4 and $6 a month to use, and that blocks all gambling websites, apps, depending on where it's coming from. Sometimes emails will get blocked. So for example, if you sign up with something like BetMGM, you will get emails for daily free spins or promos. That's really common when you engage in gambling apps online or in person. Your like a Gateway Casino in Clinton, they may send upcoming promotions or events that's doing that casino. So depending on where it's coming from, it can block it. But so GamBan is a paid one. Then a free one that works just the same way is called BetBlocker. So both BetBlocker and GamBan are VPN-based blocking apps. So and we use this. This is a common, we call it a self-binding technique, but a common strategy that we will help to implement with clients that are struggling with gambling addiction. Also, depending on the severity of it, is something called self-exclusion. Self-exclusion has been around for, probably 25 or 30 years. It started when gambling was, again, we call them land-based or those brick and mortar casinos. If you were struggling with gambling, and again, as I touched on, you can't go back to moderate use, you can't go back to casual use when a gambling addiction sets in. That's something very unique versus other addictions, whether they be substances or other problematic behaviors. You have to stop. There's no reduction. So self-exclusion is something you would do at the casino, where you would sign up to have anywhere from 1 month up to 5 years, that's what they used to call their lifetime ban, but it goes up to 5 years, where you cannot you can't go into an in-person casino. Or when you do the self-exclusion app, it's set up the same way, where you cannot go and access gambling websites. They connect, the app is connected to your profile. So if you have an Apple phone, you have an Apple profile. If you have something like an Android phone like Google, you have a Google profile. So if you were to get a new phone, and you go ahead and install it, kind of get the new phone set up, that blocker goes, oh yeah, this is still you. You can't delete the app. So it really does carry with you as you get new phones until your self-exclusion period is up. So both of them are really, really helpful apps for folks that are struggling with gambling, whether they be clients that are coming into my office for counseling supports, or if we have somebody that comes in for our drop-in times. We offer drop-in at the Stratford office at 10 Downey Street, Monday, Wednesdays, and Fridays from 1 to 4. In Goderich at our Kingston office, Mondays and Fridays from 1 to 4. If folks come in for that and they're struggling with gambling, we will go ahead and support them in downloading either GamBan or BetBlocker onto their phone, other devices they bring. So that is something great. If that feels a little bit overwhelming, you can, if you're in the area, London is probably the closest one. They have something called a Play Smart Center. We don't have one in Clinton. Larger casinos have them where they are built within the casino. They partner with OLG to help promote responsible gambling. So you can go and talk to somebody about your gambling habits. How can I play more responsibly? They can give you some strategies to cut down and reduce your gambling if it's not addictive. But if you are if we are struggling with a gambling addiction, it's no gambling whatsoever to help you maintain the symptom management.
Thank you, Meaghen. It was wonderful to learn that there's a couple different options out there for people who are struggling with gambling addiction and who are looking to get help. I actually wanted to ask you a quick question. How do you know someone has a problem with gambling, and what can someone do to help them out?
Definitely. So when we talk about addiction in general, and this is also for gambling addiction, I also really, really want to specify gambling is not a choice. Gambling is not done out of someone who is not trying hard enough. It doesn't matter somebody's intelligence. It also doesn't matter regarding somebody's socioeconomic status. Gambling is something that we do in a nutshell to try to manage emotions, stressors, that we are not able to regulate and manage in other ways. So that's how gambling develops, that's how addiction develops, and it doesn't discriminate. So, so when we think about people that are struggling with addiction, we don't talk about looking at certain populations. It's applicable for anybody. And where we look at gambling addictions, where it can also be similar for other addictions as well, is I ask folks to really look at noticeable changes in their friends or their loved ones. Have you noticed that maybe their sleeping is really, really disrupted? They're maybe going to bed at wee hours of the morning, getting up very late during the day. They're not eating well. Perhaps they're also a little bit more agitated or aggravated, and they're retreating more. They're closing off like their friend circles. They're not connecting with family members very well. And depending on what the addiction is, and this is even for gambling, you may notice some slight increases in behaviors. So I think a common one is maybe, you have a loved one where I know like a couple nights after work, they have 1 or 2 beers. And then you notice again, along with maybe like they're retreating, or perhaps they're becoming a little bit more agitated. Sleeping is disrupted, eating is disrupted. They're starting to drink more alcohol. So we think about, are you noticing that? With gambling is what we also look at as being a hidden addiction. You could be sitting across the room from somebody and you could see they're on their phone, but you have no idea what they're doing. Or someone could say, hey, I got to go to the grocery store. I'll be back in 2 hours. And they end up going to a casino and you may not know. So when we think about gambling specific, I encourage, again, folks to, again, pay attention to those more physical traits, changes in those that I mentioned. And if you notice things around finances or spending, so it can be something where maybe you have a loved one who doesn't ask for money, that's all of a sudden regularly asking you for $50 here, $75 there, $100 there. So noticing kind of asking for borrowing money, or if it's something like you have a shared bank account, you start to notice unrecognizable charges, because when somebody's online gambling, on your statement, it's not going to say BetMGM. It's not going to say sites. It's going to say something random, like it could be a person's name. You don't know. So you'll start to see maybe $2 charges up to charges within the thousands of dollars. If you're not sure about them and maybe your loved one isn't being forthcoming with that information, that's also something to keep an eye out for. Or again, I also think about, sports. I'm a big baseball fan, and I'm aware anytime you watch a sports game, they're just inundated with commercials for different types of online gambling platforms. As I said earlier, we do need to regulate those like we do tobacco. But if you notice that your loved one cannot watch a sports game without betting, that's problematic too. Even if it's something like $3 or $4, if they cannot watch a game without betting something, that's a red flag. That's something I keep an eye out for. Again, gambling at its form is entertainment. And it's also tricky too, because in rural communities, there's not a lot to do outside of work. So a lot of people, again, we see it a lot with mostly our male clients, where they'll all get together to watch, Friday night football, and they'll all sit and they'll all make bets, or they'll make their fantasy football leagues. So it's starting to become more integrated with our culture, but we're not able to see the negative impacts of it. So that's something I encourage for you to pay attention to your loved ones. If they can't enjoy their sports without gambling in some capacity, that's problematic. So those are some things I encourage folks to look for in their loved ones that may be struggling with the gambling addiction.
Thank you again for that wonderful answer. You're definitely right. Gambling is incredibly pervasive in today's society. You're right. You see it everywhere on TV, all different kinds of advertisements, and it is hidden as well. So it's very hard. So for those in the audience who are listening, I hope you paid attention to some of the different signs that you might see, and you can now figure out a little bit more about what to do to help those around you. I know you mentioned gambling as entertainment. Is gambling something that people can do responsibly at a minimal level? Are there strategies people can take if they're thinking about engaging in it in a certain level?
Yes, absolutely. Gambling and any other, again, I know I listed a variety of the problematic behaviors I support, even things like substance use. When folks come in and access services, I tell my clients, I'm not really interested in what you're doing, it's the how. So it's the how we engage with something that can become addictive or problematic. So gambling, I will gamble the odd time myself as a form of entertainment. So it's being mindful of how it's done. So I feel like it's a bit of an old saying, but know your limit, play within it. That's really, really big. So when you decide to gamble, whatever form it's in, make sure that you go in with a budget set. And I tell my clients, I'm not really concerned what the budget is, as long as it doesn't impact other bills or necessities you have to pay. So if you want to go to the casino, or you want to go play, BetMGM online, and you want to spend $500, if you have $500, that's not going to impact your, your car bill, your rent, grocery money, anything like that. That's good. So you set the budget that works for you. And when you run out of your $500, you're done playing. So I tell my clients, make sure you set that budget. I encourage clients to go with other people if you're going in person to go gamble, because when you go by yourself, accountability can start to wave and not really be there. I recognize people I work with have gambling addictions. So if they're not ready to stop, because again, that's not my place to decide that, I say, if you are still going with somebody, or if you're going to gamble, I want you to bring somebody else. Even if you don't have a gambling addiction, I encourage that. You can help to hold each other accountable. So keep within your budget. Also, make sure you take breaks regularly. There are people that will spend hours at the casino. If they're gambling within their financial limit, again, that's fine. But we talk about, especially if you're at work or sitting at your computer desk, every 15 or 20 minutes, get up, stretch, get something to eat, get something to drink, take that 5-minute break, and then you can go back. So also make sure you take regular breaks. Those are some things I encourage clients to do. If you start to notice that you gamble, and when you exceed your limit, you're still wanting more, or you're expecting or thinking you're going to obtain, in this case, more money with gambling, that's when maybe a little bit of some red flag warning signs are going to go off, because again, you will never get to decide or predict how much you win. Gambling in all forms are random. So if you start to notice that or get worried, or if you lose, you start to become much more depressed with it, aggressive with it, really, really struggling with managing that, that's problematic too. So I hope that those are some helpful tips of how to responsibly gamble, and how you can also just notice some things for yourself if you're worried about your own gambling as well.
Thank you. I think those were incredibly helpful, and I hope people have gained some insight now into what they should be doing if they're ever thinking of gambling. as a form of entertainment. I wanted to now pass things over to Kathy Liu. I just had a question for you. So plenty of mental health care and treatments occur at an individual level. And I noticed in addition to your clinical work, you've done research looking at quality improvement and healthcare system strengthening. So why is taking a population approach also important for treating mental health and addictions, and what does that look like?
Yeah, I think that's a really good question. I think having a population-oriented approach to treating mental health and addictions is really crucial, in my opinion. The ultimate goal of having a population approach is to ensure that the different needs across the lifespan and across demographic groups are all equally accounted for in an inclusive manner that would help eliminate any inequities in mental health, whether that's access or treatment or continuity of care, and making sure that all the different socio-demographic factors that would influence recovery are all taken into account. So I think it's basically, so when we look at one individual patient, it's a very micro level perspective on treating mental health. But once we zoom out of that and arrive at a population level, that's a more comprehensive kind of assessment of the population needs and what the community needs. When we, I think, ultimately become accountable for the entire population versus just one or two individual patients, I think we're much more, we're in a better position to understand how individual factors and the different population trends feed into mental illness. We can better understand why there are different utilization patterns when it comes to access or consumption of mental health resources. And we're able to better understand the different recovery trajectories across different groups and really ask ourselves, how can we better care for everyone instead of just one individual group or individual groups of patients, by taking into account race, ethnicity, and geography, which I think would ultimately result in a stronger and a more equitable mental health system across different geographic areas.
Thank you, Kathy. I think you're right. It's definitely important to take a population approach when you're looking at caring for mental health. As you said, it really does increase the ability to deal with diversity and to promote equity and inclusion. For the sake of time, I'm going to move things over to Nicki. I had a question for you about sort of your work in connection with the Maitland Valley Medical Center. So what does it mean to be acting as a part of a family health team? What are some of the strengths and team-based models for care, especially in the case of providing support for mental health?
Yeah, thank you so much. So we often say how lucky we are to be part of this team, not just here at the Maitland Valley, but in family health teams where we have access to so many specialists under the same roof. So the research suggests for treating anxiety and depression, for example, that therapy in conjunction with medication can be the best way forward. And often when we have this relationship with the primary care provider where we can, with the consent of the client, communicate about their care, we have this team then who's looking out for their best interests, and we're able to come up with a treatment plan as a group, so to speak. And I did mention we do have these specialists here on the team who we can refer to quite easily, in terms of dietitians who do work with eating disorders. We do have a smoking cessation program that I forgot to mention, and Michael, thank you for reminding me. We do have somebody who does that here. So we do have these services that we know about and that we can kind of bring together as part of a group. And really, when it comes to treatment planning, it's just much better to have that collated approach. Yeah.
Thank you. Yeah, it's definitely great that we have these family health teams that exist in the area, especially in rural settings where without them, I think the continuity of care and the access would definitely be decreased. Um, we've touched on it a little bit, but I wanted to ask you a little bit about mental health in terms of stigma, because mental health is such an important topic, especially as of late. And there's an estimated 1 in 5 Canadians who are struggling with mental health just in this year. But there still seems to be a lot of stigma, especially around seeking support. So, what does it mean to destigmatize mental health supports, and what does that look like, especially for an area like Goderich and a rural, remote community?
Yeah, I think it's really like from my perspective, it does feel like it's an ongoing conversation. Having these groups that we're talking about and sharing as a group here at the clinic. But often it starts in the doctor's office, which, because people go to their doctor and they often share what their presenting concern is for that day. It really is the doctor who's saying, you know what, you could try this. Like, we have this service here. And so a lot of the work is being done really by the primary care providers in that moment, for family health teams. And we really appreciate that kind of um, destigmatization, right? Because we'll say, we're biased, but we think everybody could benefit from counseling, right? We think that everyone can benefit from this, but really it's the doctor who's like, you've got a lot going on. Why don't you consider, having this triage call and seeing if it's a good fit for you, right? So that's kind of how it would work from the family health team perspective. But from what our perspective, like the bigger picture, we are trying to do groups in the community for free to really give access. And going into the schools, like, it really does feel like that's the preventative community work that we're finding serves people in that regard. And just, yeah, we all have these things. It's like a spectrum of we talked a little bit about the nervous system and how we're all kind of going back and forth between feelings of safety and fight and flight and like low mood kind of dorsal states. And we all move in and out of those states all the time, right? So let's normalize this and like let's get to know our states and let's get to know what we're feeling, and we can talk about it more freely. Yeah. Thank you.
I wanted to see if any of our other panelists had anything to add regarding destigmatizing mental health and accessing mental health support.
I think Nicki spoke to it very, very well. And that's work we also try to do here as well. Again, I recognize that today I'm talking about the addiction side of things, but addiction and mental health do go hand in hand. That is why in 2023, we had two agencies that amalgamated. At the time, I was with the Historic Choices for Change agency that focused on the addiction part. But having the amalgamation of services, because we recognize that mental health is incredibly prevalent in addiction. But again, we don't, even outside of that, we're not talking about it enough. So the work to normalize and talk about mental health challenges, it's applicable to everyone. We talk about, you can have a mental illness, but you can still live in mental wellness, or you can have challenges in your life. We will all experience things like moments of being really, really depressed or anxious, and we can have not living in mental wellness. So us being able to talk about it and destigmatize it normalizes these things and allows folks to feel comfortable accessing it. Again, I can't speak for Nicki, but I do recognize a lot of my male clients, when we talk about the addiction part, they start to get a little bit touchy when we start dipping into the mental health piece, because they think that it's something about them that's defective, or they didn't do something right. So really destigmatizing and talking about all of us are impacted by mental health regardless, is so important to have a community that is well. And we do see a lot of that need in our rural community. So the work that Nicki and that Kathy are doing are invaluable to our rural communities that we live and work in.
Thank you for adding a little bit more onto how we can go about destigmatizing mental health and how we can better create conversations surrounding the topic, because I know it is a sensitive one. I just wanted to thank you all for presenting today. It was really nice to have you on, Meaghen, Nicki, and Kathy. I hope that everyone listening today came away with a little bit better understanding about gambling and problematic behaviors, but also rural mental health in general, and different ways that you can support those around you and different ways you can get help yourself. I just wanted to thank the following sponsors for their continued support for today. Without them, the lecture series would not have been possible. So I'd like to give a big thank you to CIBC Wealth Management, DeJager Town Square IDA Pharmacy, Hurontel, Lighthouse Money Management, McEwen and Fegan Insurance, and Zehrs Goderich. I just wanted to mention again that Gateway is a not-for-profit organization with a charitable status, and we greatly appreciate and welcome any support we receive. We will be continuing this conversation In October, speaking with Kathy Vasilakos, who is the director of United Housing, where we will discuss affordable, attainable, and adequate housing in rural spaces. Once again, thank you to our great panel who came out today. Thank you to our sponsors, and a great thank you as well to our audience for coming out today and hearing what we have to say. Thank you, everyone, and I hope you all have a great day.